Good. Good. Bismillah ar-Rahman ar-Rahim. Okay, Bismillah ar-Rahman ar-Rahim, and good morning. Today I will talk regarding the anatomy of large intestine, of anatomy of lower GI. I think I will try during this 1 hour to cover everything, but I think maybe I cannot, but you need to read after that, but I will try my best to cover everything. Okay, Bismillah, we start. Okay, if I say large intestine, what I mean by that, large intestine is, I mean by that, it consists of cecum, colon, rectum, and anal canal. And usually around 1.5 meter longs, okay? And there is unique feature for large intestines, okay? This feature make us differentiate this is large intestine or small bowels, okay? One of unique features, the first unique feature of large intestine is tinea. The second one is the hystrations. The third one is omental appendices or epibolic appendices. Are you okay? Are you hearing me, guys?
Yes, Mr.
Okay. As I told in the previous slide, there is 3 unique features for large intestine. The first unique feature is tinea coli. What the tinea coli? The tinea coli is longitudinal muscle bands run along with the length of the colon. There are 3 tinea coli running parallel to each other along the colon. The first, did you see the pictures?
Yes.
The first tinea coli we call tinea mesocolica. This tinea is running near to the mesentery of the large bowels. Okay. The second tinea we call tinea labra or free tinea. This tinea present, if you see in the pictures. Okay, did you see my mouse?
Yes.
And the anti-mesenteric border. This is the mesenteric border. This is the tinea. If you see here, this is the tinea mesocolica. The name coming from the mesentery, mean near to the mesentery. And this is the tinea called tinea labra, free tinea, because it's in the anti-mesenteric border. The other third type of tinea we call tinea omentalis of the colons. You see, we have 3 types of tinea, and the tinea is coming from the longitudinal muscle bands. Okay. The second feature for large intestine presenting of hystrations. Why the large intestine? What meaning of hystration? Meaning if part of the colon is bulging outward. If you see here, the bulging here and the bulging here, and between the bulging there is cleft. Okay, if you open the colon and you look what this cleft, the cleft inside the colon look like, we call it semineural vaults. This is crystal-like mucous membrane between the, you see here, between the hystrations. Okay, why the colon having hystrations? Because the tinea contracts the colons. You see, the tinea is make the colon contracted. When the colon contracted, the part from the colon bulging outward and forming the hystration, one of the features of the large bowels. The third feature, unique feature of the large bowel is epibolic appendices. This is, small pouches of peritoneum filled with fat. Okay, if you see here in the pictures, and this can cause very rare condition because epibolic appendices. This is patient presenting with abdominal pain, usually mimic to the acute diverticulitis. We did CT scan, we identify them. How we this condition, usually the self-limiting conditions. Okay, why it has this appendices can be twisted or become thrombosed. Okay, now we go by details by part, but as I mentioned my first slides, the large bowel consists of cecum, colon, rectum, and inner canal. We start discuss about the cecum. Cecum located in the right iliac fossa, everybody as know, and if you see here is projected downward below the ileocecal junctions. Regarding the measurement, this is about, I think if you look different book, they give, maybe 1 to 2 centimeter different. I think it's about, the cecum measurement is about 5 to 7 centimeter in length. Okay, if you noted here, the cecum have 3 tinea, 1 in the anterior wall, 1 in the posterior down, 1 in the medial side. All these 3 tinea met in the base of the appendix. This is why when we try to do the appendixectomy, how we look for the appendix, we just try to follow the tinea. Where's the area the tinea is converged together from the anterior part, posterior part, and medial part. This is the base of the appendix. This is how you can identify the base of the appendix. Clear until now?
Yes, Mr. President.
Okay. Cecum is intraperitoneal with variable mesentery. There is about 5% from people, the peritoneal in the cecum is incomplete, and this is leaving the posterior surface of the cecum connected to the right iliac fossa, to the iliac fascia by connective tissues. You mean is intraperitoneal organ, but there is 5% of people have incomplete peritoneum covering the posterior wall is without peritoneum. What the relation of the cecum? This picture shows the relation of the cecum. If you see anterior, sometimes we found coolest of small bowel, sometimes greater omentum in the front, and anterior abdominal wall in the right iliac regions. Posterior, there is 2 muscles, right psoas, iliacus muscle, and if you see here, 2 nerves, femoral nerve, and lateral cutaneous nerve of the thigh. And sometimes the appendix we found behind the cecum, this we call the retrocecal appendix, and this is about more than 60% of patients, and we will talk about that later. Medially, usually, the appendix coming from the posterior medial side of the, of the cecum. The relation again, sometimes coiled of small bowel, greater omentum, anterior abdominal wall. This is anterior posterior 2 muscle, psoas muscle, iliacus muscle, 2 nerve, femoral nerve, lateral cutaneous nerve of the thigh, and sometimes the appendix. Medially is, appendix arrays from the posterior medial sides. Blood supply coming from the hand gut. The blood supply mainly from the inferior mesenteric arteries, superior mesenteric artery, sorry. Superior mesenteric artery giving the ileocolic arteries. Okay, sorry for that. I will go back. Giving the ileocolic artery, they're giving anterior cecal artery and posterior cecal artery. Posterior cecal artery give a branch of to the appendix, and the blood supply from the cecum coming from superior mesenteric artery through the ileocolic artery, which divided to posterior and anterior cecal artery. The nerve supply of the cecum, coming, as we know, coming from sympathetic and parasympathetic, through the branch of the ileocolic branch from the superior mesenteric plexus here. Okay, the lymph node go, and this nerve usually follow the artery. Also, the venous train, ileocolic vein, going to the superior mesenteric veins. For the lymph node, there is lymph node around the ileocolic artery called ileocolic lymph nodes. Okay. The second part from the large intestine is the appendix. If you see here the picture, the appendix is look like blind diverticulum. If you noted here is the rising from the posterior-medial aspect of the cecum. And if you looked here, this is the ileocecal valve, and this is the appendix orifice. And if you see the distance between the ileocecal valve and the appendix orifice is about 2 to 2 centimeters. You know, what we call the orifice of the appendix, 2 to 2.5 centimeters below the ileocecal valve. And there is valve here guarded the appendix, we call Clarchik valve. How long the appendix? The average, some books say 9 centimeters, some books say 7 to 8 centimeters, but the range of the length of appendix is from 1 to 20 centimeters. What the width of the appendix is about 0.6 millimeter or 0.6 centimeters. Some books say 5 millimeter. And when we do the CT scan to diagnose appendicitis, usually you see the thickness is more, if there is more than 0.6 centimeter, this is meaning inflamed appendix. The appendix consists of 3 parts: the base, the body, the tips. Where is the appendix located? The appendix, as we know, located in the right iliac fossa. If you noted here, the base always fixed, but the tip have variable positions. If you see here, you know, this is we call paracolic. Okay, is about 2% of patients they have that. This is in 11 o'clock positions. Okay, if you look here, this is we call retrocecals. This is the most common one. Is about more than 60% of patients having this position. Retrocecal in the 12 o'clock positions. Okay, this is, you know, the position of the, which one is the most common? I think if you see the paper coming from Iran, showing, you know, the pelvic one is more common, but most of the paper coming from the other country, the most common one is the retrocecal. Is about more than 60% of the patients. Okay, if you noted that in the 2 o'clock, there is another position, is pre-aerial, is about 1%, post-aerial 0.4 to 0.5%. Okay, promontoric, this is very rare position, the tip of the appendix. The tip usually going to the promontory of the, you know, sacrum. Okay, if you look at this is the pelvic positions, is about more than 30% of patients they have this position. This is in about in the 5 to 4th o'clock. The one is subcecal or mid-inguinal. The tip of the appendix directed to the inguinal ligament is about, this is about 2 centimeters. The position of the tip of appendix is clear, guys?
Yes, Mr. Brother.
Okay. Appendix also, this is intraperitoneal structures held in the place by the mesoappendix. Okay, did you see my mouse?
Yes.
Okay, and how the mesoappendix coming from? They're coming from the posterior or left layer of the ilium mesentery. And if you see here, you know, in the free border of the mesoappendix, there is a appendicular artery running and supplying the appendix. Appendicular artery coming from the posterior-cecal arteries, branch from the ileocolex, branch from the superior-mesenteric arteries. Again, you know, this is a slide show the appendicular artery comes from posterior-cecal artery, branch of ileocoelic artery, branch of the superior-mesenteric arteries. It's here. This is the posterior-cecal branch from the ileocoelic artery, branch of the superior-mesenteric arteries, and this is the appendicular arteries. Also, the venous drain is corresponding to the appendicular veins, and both of them presenting in the mesoappendix. So the appendix supplying from sympathetic and parasympathetic, same coming from what we call the ileocoelic branch, this branch coming from the superior-mesenteric plexus. Also, the afferent limb of the sympathetic, you know, coming from T10. This is why in the patient with acute appendicitis, presenting the pain starting around the umbilical 1 hour after that shifting to the right iliac fossa. This is why, because the afferent fiber coming from the spine, from the T10 and the spinal cord and going to the appendix. So far clear, guys? Any questions?
Yeah, Mr. President.
Okay, now we're coming to the colon. Okay, if you see, this is picture showing the measurement of the colon. You know, I told you the measurement is different from book to books, but this is approximately. Okay, you see here, show the cecum, you know, is about 5 centimeter length, 8 centimeter. I told you before that's 7 to 7 to 6, whatever. You know, but the most important here, the cecum is the widest, and this is most likely this is to have perforation in the to have obstruction due to the cecal tumor can be happening, but you know it's very rare because of the wider. But you can have perforation there. And if you see the most narrow part is the sigmoid colon, and it's about 50 centimeter, and the sigmoid colon, this is why usually the left side colon and the sigmoid colon tumor more likely to present with obstructions. Also, you know, the most common side of diverticular disease happening in the sigmoid colon because of the narrowest part of the colons. Okay, if we come to one by one, this is the ascending colon. Ascending colon, you know, is about, as I told you, is about 10 to 20 centimeter long. If you noted here, started after the ileocecal junctions, okay, going caudally, cranially to the caudal liver surface here, we call this as the hepatic flexures. After that, you know, having sharp turn 90 degree to become the transfer colons. Okay, start from here, going cranially until the caudal surface of the liver, become the hepatic flexure. After that, have 90 degree turn and become the transverse colon. It is retroperitoneal structures, okay, covering in his ventral side and lateral surface by peritoneum. Okay, and if you looked here, adjust to him, we call that there is right paracolic gutter. Did you know the clinical significance of right paracolic gutter, guys? Anybody can answer me. What the significance of gutter? This is the left paracolic gutter beside the descending colon, and this is the right paracolic gutter beside the, you know, the ascending colon, and between the colon and the posterolateral surface of the abdominal wall. What the clinical significance of the gutters?
Yeah.
Anybody?
Is it the potential space, Mr. President?
Yes, any inflammation in the organ can be collection in these gutters. Okay, yeah, any inflammation in the organ around here can be collected in these gutters. What the relation? Okay, this is also picture show the relation. I don't know if it's clear or no. If you see the anterior to the sigmoid colon, we found, you know, ascending colon, you found the small intestine, coils of small intestine, greater omentum, and anterior abdominal wall. Sorry for that. Posterior, you have two muscle, iliacus and the quadratus lumborum, right kidney. There is two nerve, iliohypogastric, ilioinguinal nerves. The blood supply of ascending colon, as I told you, same like before, ascending colon is hand gut in origin. Mainly blood supply coming from the superior-mesenteric arteries. Superior-mesenteric artery giving the right colic divided to the ascending branch and descending branch, and this is supplying the what we call the ascending colon. Also, ascending colon blood supply come from the ileocolic artery also, okay? And the vein, usually ileocolic and right colic vein, okay? Usually the vein combine the arteries, and the vein from the ascending colon going to the severomesenteric veins through the ileocolic and right colic veins. Also supply from the sympathetic, parasympathetic through the ileocolic branch of the severomesenteric plexus. Okay, the lymph node is ileocolic, and the node around the ileocolic artery, also the right colic arteries. Okay, the fourth part of the large intestine is the transfer colons. Transfer colon, is about 50 to 45 centimeter in length, and extended across the abdomen from the hepatic flexure to the splenic flexures, as I'm showing here in the pictures. And this is the transfer colon, the most mobile segment of the large intestine, since suspended by the transfer mesocolon. Okay, this is why usually we, when we have sometimes obstruction down here, we bring we have what we call the transfer colon colostomy. Okay, because this is the most mobile segments, okay, and the colons. We don't have any colostomy done here, loop colostomy, especially in the descending and ascending colon or descending colon, because this is both of them is retroperitoneal and fixed, and they don't have true mesentery. But usually, if we want to create colostomy using transfer colon, using sigmoid colon, also we will talk later about this. Also, this is mobile and have free mesentery. And sometimes we're using the cecum cystectomy. Okay, clear?
Okay, clear.
Okay, and as I can go back, and in the left extremity of the transfer colon, as I show here, turns inferiorly and sometimes somewhat posteriorly at the splenic flexures to become the descending colon. And clinical important here, if you noted here, this is we call there is some ligament here. If you want to mobilize it, the splenic flexure, when you do left hemicolectomy or the anterior resections, and there is some ligament we need to take out, and you have to be careful when you take this ligament not to injure the spleen. One of them, the splenocolic ligaments. Another thing, what we call the what we call the freno. There is ligament coming laterally and posterior from the colon and attached to the diaphragm, if you noted here, and also attached to the lower ball of the spleen. We call it phrenocholic ligaments. Also, we need to take this ligament out to release the splenic flexure during our left hemicolectomy, or what we call high anterior section, if you need to mobilize the splenic flexures. Clear until now, guys?
Yes, Mr. Vedar.
Okay. What the relation to the transfer colon? Okay, this picture shows the relation to the transfer colon. If you come anteriorly, you found the greater omentums and the anterior abdominal walls. Okay, posterior descending part of the duodenum, head of pancreas, coils of jejunum and ileums. Okay, and superior relation, you will find what we call the liver, the gallbladder, greater curvature of the stomach, lower end of the spleen here. Okay, inferior relation, if you see here, this is a small intestine. Okay, this picture shows the relation of to the transfer colons. Okay, if you noted here, the blood supply of the transfer colons. Okay, as you know from embryology, The hand got you know, the organ from the colon, large intestine, originated from the heart, got started from what we call cecum until the proximal 2/3 of the transfer colon. This whole area supplied by the mesenteric, severomesenteric arteries. As we discussed early, you know, branches of severomesenteric arteries responsible the blood supply of the cecum and ascending colon, ileocholic artery, right cholic artery with his ascending and descending branch. Okay, if you noted here, there is artery we call middle cholic artery. This middle cholic artery giving the right branch and the left branch. The middle cholic artery is responsible and coming from the severomesenteric artery. And this is responsible for the blood supply of the what we call the transfer colon. And if you noted here, this is the right branch of the middle cholic artery. You know, make anastomosis with the ascending branch of the right cholic arteries and supplying the hepatic flexures and, you know, supplying the part from the proximal 2/3 of the what we call the transfer colon. If you're coming to the distal 1/3 of transfer colon, this part supplying by what we call the ascending branch of the left cholic artery. And the ascending branch of the left cholic artery make anastomosis with the left branch of the middle cholic artery, and this is supply the other part of the transfer colons. Is clear or confusing?
Clear, Mr. Mehta.
Yeah, okay, sure. And the lymphatic drain, you know, the venous also from the middle colic vein going to the severomesenteric veins. Okay, and the what we call the nerve, same from sympathetic and parasympathetics, coming from mainly from the until the proximal 2/3 coming from the severomesenteric plexus, and all this area supplied by severomesenteric plexus, sympathetic and parasympathetic. And after the splenic flexures, the nerve supply coming from the inferomesenteric plexus through the what we call pelvic splenic splanchnic plexus also. Okay, clear?
Clear.
Okay, and now we're talking about the descending colon. Descending colon is about 22 to 30 centimeter in length, located within the anterior left pararenal space. Here, extend vertically from the splenic flexure to the left iliac fossa. To be after that can be continuous with the sigmoid colons. Okay. As I discussed before, I think I said ascending and descending colon, both of them is retroperitoneal structure and fixed. They didn't have true mesenteries, okay? And as I think I discussed in the early slide, I said the caliber here, comparing with hair, the hair is more smaller. This is why usually most of the patient in the left side colon cancer presenting with obstructions. Okay, and it's retroperitoneal, covering along with anterior and lateral surface pyoperitoneum, and he didn't have any true mesentery. Relation to the descending colon, same, you know, colons of small bowel, greater omentum, posterior lateral border of the kidney, you see here, okay? And there is some muscle lying posterior to the descending colon, like transfer abdominis muscles, quadratus lumborum, iliacus, and left psoas. If you noted here, there is bony also, the iliac crest, lying posterior to the descending colon. There is some nerve lying posterior to the descending colon, like iliohypogastric, ilioinguinal nerve, and the lateral cutaneous nerve of the thigh and the femoral nerves. Now we're coming to the sigmoid colon. Sigmoid colon, you know, is shape. If you see his shape look like S, okay, is about, you know, I think 35 to 40 centimeter in length. As I discussed before, start in the left iliac fossa in junction with the descending colon, crossing the pelvic brim, enter the pelvic cavity, where becoming and continue with the rectum at the S3, at the level of S3. Okay, this is the sigmoid colons. Okay, and is completely surrounding by peritoneum, and it's also he's mobile too. This is why usually we have the loop sigmoid colostomy for that. Okay, and suspended by the sigmoid mesocolon, and the blood supply is, this is, we call this coming from the hand gut. Okay, and hand gut, usually the blood, mainly blood supply of the hand gut is the inferior mesenteric artery. If you noted here, inferior mesenteric artery giving the left colic, ascending branch of the left colic, and descending branch of the left colic. And you see here, this is the sigmoidal arteries, supply the sigmoid colon. And this is the superior rectal artery. And I think that if you noted some lower part of the sigmoid colon, there is some blood supply coming from superior rectal artery, and also in the junction here with descending colon, some blood supply coming from the descending branch of the left colic arteries. The vein, same in the superior, going to the superior mesenteric vein. The lymph node, usually paracolic lymph nodes here, nerve supply, sympathetic and parasympathetics coming from the inferior mesenteric plexus here. Okay, now we coming to the large organ here, we call the rectum. This is the picture, so the anterior view of the rectums here, okay? And this is the sigmoid colon covering with the peritoneum, completely with peritoneum. And now we discuss about the rectums. Okay, if you see the picture here, this is the sigmoid colon. You know, enter the pelvic brim and continuous, after that, continuous as the rectum. If you see here, opposite to the S3. Okay, this is the beginning of the rectum, opposite to the S3. Where is it is ending? Ending is about, you know, if you noted here, this is the rectum also. Ending, you say this is the coccygeus, and the ending is about 2 to 3 centimeters in front and little below the tip of the coccygeus. If you see, this is the pelvic diaphragms, and below this, the pelvic diaphragm, you found the what we call the anal canal. This is the anorectal junctions here. Okay, started in the opposite to S3 as continuation of the sigmoid colon, ending about 2 to 3 centimeters in front and little below the tip of the coccygeus. Clear until now, guys?
Yes, Mr. Madam.
Yeah, and how a lot of definition of the rectum usually, how you know you are in the rectums, you know, you are not in the colon. And did you see the feature I discussed early, the tinea, the hastration, the epipulic appendices? The rectum, he don't have that, you know. The rectum, he don't have hastrations. You know, I told you the colon is he has 3 tinea, okay, and the rectum could be having all the tinea united in the wall of the rectum only, okay, and there is a lot of definition of the rectum. Some people, they define the rectum when you when there is, you know, this is the sigmoid mesentery. They defined by the take off of sigmoid mesentery. If you don't find any mesentery here, this is meaning this is the beginning of the rectums. Okay, the rectum, he don't have any free mesentery like the sigmoids. Okay, and another definition by the what we call you know, how to know you are in the rectum, not in the sigmoid colon, by what we call the sacrobonometry. Sacrobonometry, usually the rectosigmoid junction is opposite to sacrobonometry here, and after that, this is the rectum. Clear until now?
Yes, Mr.
Okay. How long the rectums? 10 to 14, 10 to 15 centimeter long. Okay. Diameter is about 4 centimeter, and the lower part of the rectum is dilated. We call it rectal ampulla. Okay. What the unique of the rectum? The rectum is he has two anterior-posterior curvature and 3 lateral curvatures. Where is the anterior-posterior curvature? One in the sacral flexure. This is the rectum follow the curvature of the sacrum and coccygeus. And there is one called perineal flexure. This is where, in the anorectal junctions, going backward in the anorectal junction, this is another flexures, okay? The 3 lateral flexures, 2 of them in the right side, the upper and the lower, and 1 in the middle side. This is the most prominent one. The rectum, he has convex in the right side. This is one curvature, one of the lateral curvatures, and another convex in the left side. This is the middle lateral curvature, and another one is in the right lower side. There is another convex. This is we call the lower lateral curvatures. The curvature is clear. 2 anterior posterior curvature, 1 in the sacral flexure, 1 in the perineal flexure, and 3 lateral curvature, 2 on the right side, convex in the right side, and 1 in the convex in the left side, and the most prominent one. Clear?
Yes,
Okay. What the relation of the peritoneum to the rectum? I think most of you they know. The upper third of the rectum is the upper third in the rectum is in covering by anterior and into side by peritoneum. The middle third only the anterior covered by peritoneum, and the lower third without any peritoneum. Okay, it's clear here.
Yes.
Okay. And this is this is for me is important slide because this is if you understand that because you are still in the first year, when you reach to the 3rd or 4th year, and even after you graduated from the master, you need to do the pelvic dissection of the rectal cancer. You need to know where you're going exactly. If you know the plane, you will be safe and you can save your patient. If you don't know the plane, you will be danger in terms to injure the crucial structure here. Also in terms of recurrence, if you don't do the surgery properly, the patient will have recurrence. You need to understand, for example, this is the rectum. Around the rectum is the mesorectum. Okay, the mesorectum is some blood vessels, lymph node, and everything. Covering by the mesorectum is the rectal proper fascia, if you see here. Okay, and this is the rectal proper fascia. Okay, and there is another fascia, is important fascia called the presacral fascias. Okay, your plane, when you try to resect the lower rectal cancer, you have to go in this hollow plane between the presacral fascia and the fascia propria of the rectum. If you go here, if you breach the presacral fascia, you will injure the structures here. There is venous here. There is vein here. Vein without valve with high hydrostatic pressures. you will have a lot of bleeding, and this bleeding usually difficult to control, and maybe you lost your patients. Okay, if you go here and bridging the fascia propria, you will injure all the structure here, the lymph node, the blood vessels, and everything, and this is not a proper TMA. Okay, you will lift a lot of tissue, you know, in your surgical field, and patient who will come with recurrent early. You need to go in the whole plane between the presacral fascia and the fascia propria. Okay, and if you notice here, this is presacral fascia. If you follow the presacral fascia, okay, and after that, the presacral fascia is reflected here, formed Waldari fascia or rectosacral fascia. Okay, and this is, you know, okay, sorry for that. Okay, fascia, Denovirus fascia. This is, I think, French surgeon, and this fascia between the rectums and the umbilical structure in the male, like the semilunar vesicle and the prostate, and in the female, the lower part of the vagina. Your dissection should be in the plane between the fascia and this structure. Also, there is hollow plane here. Clear about the fascia and the rectums and covering of the rectums?
Yes, Mr. Veda.
Okay. What the relation of the rectums? I think relation is different between male and females. Okay, if you noted here in the pictures, this is the rectums. Okay, and the upper two-thirds there is rectophysical pouch. Usually in the rectophysical pouch, you found the colon of the small bowel, also sometimes in the sigmoid colon. In the upper two-thirds anterior in the males. Okay, and the lower one-third you will find the base of the bladders, urinary bladders, ureters. I'm appointed here. Okay, semilunar vesicles and the prostate. This is in the males. Clear?
Yes.
Okay. In female anterior, if you see her, in the upper two-thirds there is rectouterine pouch. Same like the male, containing the coils of small bowel, sigmoid, and this pouch is separated the rectum from the uterus and upper part of the vagina. Okay, the lower one-third is related to the lower part of the vagina. This is the anterior relation in the females. Okay, to the rectums. Clear, or you want me to repeat?
Clear, Mr. Veda.
Okay, good. What are the posterior relations? Okay, 3 bones, 3 muscles, 3 vessels, 3 set of nerve, 3 other structure. 3 bones is lower 3 sacrum, okay, coccygeal and iliococcygeal ligaments. Okay, okay, clear. The muscle is performance, coccygeus and levator and eye muscle. This is posterior. Blood vessels, median sacral blood vessels, superior-rectal. Usually the superior-rectal coming behind the rectum, not in front of the rectum, okay? And lower lateral sacral vessels. There is sympathetic chains, okay? And there is lymph node and lymphatic. This is the posterior structures of the rectum for both male and females. Clear?
Clear, Mr. Veda.
If you looked inside the rectum, we open the rectum and we looked inside, or we put scoop, okay, to know you are in the rectum or no, by the valve of Houston's, okay, and this is we call mucosal fold, transfer mucosal fold, okay. There is upper, middle, and lowers, okay, and sometimes there is fourth one, sometimes present, sometimes not present, but the most common is this is 3, upper, middle, and lower. If you noted here, 2 on the left, upper and lower, 1 on the right, the middle one. And the upper one usually start at level of C in the rectosigmoid junction, at level of S3, and present in the, and is about 12 centimeter from the anal orifice, And if you see presenting in the left side of the anterior rectal wall. Okay, and the middle is the largest one. Project from the right wall. A junction between the upper 2/3 and lower 1/3 is about 5 centimeters from the inner margin. Okay, and if you noted here, the lower fold also in the project from the left side, about is about 2 centimeter distance from the what we call the middle folds. There is 4-1, sometimes present, sometimes not present, and this is about 2.5 centimeter above the middle fold and coming from the left wall. It is present. Clear? Clear the valve?
Yes, Mr.
Okay, sure. Okay. Blood supply. Blood supply the rectum mainly from the superior rectal artery. Superior rectal artery branch from the, as you know, from the inferior mesenteric artery. Okay, and there is blood supply also coming from the middle rectal artery, branch of internal iliac arteries. Okay, also there is inferior rectal artery branch of the internal pudendal artery branch of the internal iliac artery. I think the middle rectal artery sometimes is present, sometimes not present. Mainly from the superior rectal artery. If you see here, the superior rectal artery coming behind the rectum, not in front of the rectum. You see? Okay. And sometimes you find the middle rectal or not, but mainly from the superior rectal and inferior rectal arteries. Okay, this is the blood supply of the rectums. Okay, and sometimes there is an artery called median sacral artery, can be contributed to the blood supply of the rectum, but the mainly blood supply superior rectal artery branch of the inferior mesenteric artery and the inferior rectal artery branch of the internal pudendal artery branch of the internal iliac arteries. This is the main 2 blood supply of the rectums. Clear? Okay, the veins same. The vein usually following the arteries in their course. You see here superior rectal artery, superior rectal vein going to the inferior mesenteric vein, and also the middle rectal vein going to the internal iliac vein, and what we call the internal pudendal vein and inferior rectal vein going to the internal iliac. Okay, and this is the vein, or usually the vein following the course of the artery, same name, carrying the same name. Instead saying artery, just saying vein. Okay, clear?
Yes.
Lymphatic drain, the upper half of the rectum going to the upper rectal and sigmoid node. Finally to the inferior mesenteric. If you noted, the arteries coming from the inferior mesenteric artery, the vein going to the inferior mesenteric vein, even the lymph node going to the inferior mesenteric node. Oh, this is why we do the highlightation in the rectal cancers, mesenteric artery. Usually the lymph node following the arteries. Okay, clear?
Yes.
Lower half is going to the internal iliac lymph nodes. Okay, usually the lymph nodes and the vein following the arteries. Okay, maybe you remember, give you some tip. If you remember the arteries, you can remember what the venous drain and what the lymphatic drain for the same. The carrying you with same corresponding to them. Okay.
Okay.
And the nerve supply of the rectum coming from inferior hypogastric plexus. Okay, this is for the sympathetic L1 and L2. Parasympathetic coming from pelvic splinting nerve S2 until S4, and as you know, the sympathetic stimulate the sphincter and inhibit the muscularity. Parasympathetic stimulate the peristalsis and inhibit the sphincters. Now to coming to the last part is the anal canal. I hope I can. I have another 5 minutes.
Yeah, Mr. Vedant.
Yes. If you see the picture here, same picture, you know, the anal canal is the terminal part of the large intestine. Where does it begin? Begin in the anorectal junctions. Totally below the perineum, below the pelvic pram, okay? And I think this is the what we call the recto-anal junctions. This is the ending of the rectum and beginning of the anal canal is about same 2 to 3 centimeters in front and little below the tip of the coccygeus. The anal canal, when passing through the levator hiatus, is going downwards and backwards. Where it is ending, opening and at the anal orifice 4 centimeters below and in front of the tip of the coccygeus here. It's beginning here and ending here. Okay, clear?
Yes.
Okay, how long the anal canal? You know, 4 to 5 centimeters, depend, you know, okay? And if you go inside the anal canal, if you put proctoscope, okay, what you found? You know, if you looked here, you will find there is some vertical ridge of the mucous membrane. If you see the, did you see the ridge here, vertical ridge?
Yes.
We call the anal column. Oh, another name, what the other name? Morgani. How many of them? Anybody? How many of them?
Is it,
Okay.
is it 15 to 20? So,
No, it's about 6 to 10. Some people say 8 to 10. Okay. Yeah. And if you see here, there is here, you see here, you see my mouse?
yes.
There is, you know, circumferential wave of mucosal fold. What we call that?
Dentate
Here.
line.
This is the dentate line. Very good. Okay. And you see, if you see the above the dentate line, this is the ridge. Vertical mucosal ridge here. This is the column. If you see the column here, in the end of the colon, there is space between the colon. We found the valve. We call it anal valve here, okay? Above the valve, we found what? The crypt and the sinus. Okay, the crypt and the sinus, there is a gland there. We call it anal gland. And if did you see the green things here?
Yes.
This is the tract of the anal glands. Okay, and this is the you see how where it is draining. What this? What this? This is the external anal sphincter. This is the internal anal sphincters. Okay, you see the gland where you're going? Going to the go through the internal anal sphincter and the intersphincteric grooves. Okay, you know, this is the gland. This is the main cause of our preanal abscess and preanal fistula. This we call the fistula cryptoglandular fistula. This is the most common cause. Clear?
Yes.
This is okay. You see, this is the dentate line here. This is the ridge Margoni columns. There is valve, crypts, sinus, and glands. Okay. Some people, they divided the anal canal to two parts, part from the anal verge to the dentate line. This is about 2 centimeters. This is the lower anal canal. And part from the dentate line until the recto-anal junction. This is the upper anal canals, okay? Some people, they divide it to 3 parts. There is part called hair transition zones, okay? Yeah, if you're going, you know, below the dentate line, what type of epithelial hair?
Squamous.
Are you sure? Hair. What type of epithelial hair? Huh?
Certified squamous.
Yes, keratinized certified squamous. What's the difference between the epithelial or the mucosa hair and the mucosa in the anal verge? Same, huh?
Yes.
What the type of epithelial? What type of epithelial in the skin? Inner skin.
Certified squamous, non-keratinized.
Keratinized certified squamous, and the epithelial hair, keratinized stratified squamous. What's the difference between two?
Similar.
Any difference?
I think the same. Mr. Mesa, we cannot hear you, Mr. Mesa.
Any hair follicle hair? Any sebaceous gland hair?
No.
No.
Any sweet glands hair?
No.
No.
No. But hair, there is. Correct?
Correct.
Yeah, this is the difference. Okay, the type of epithelial hair, stratified squamous epithelial keratinized, hair is keratinized, but here there is no hair follicle, no sweet gland, no sebaceous glands. Okay? What's the type of epithelial hair above the dentate line?
Columnar.
Columnar. Okay? What the type of epithelial and the transite zone?
Not sure.
We call transite zone, meaning mixed.
Oh, mixed.
Yes, mixed between columnar and stratified squamous. You found both. This is why we call transite zone. Okay? There is two different between two epithelials. Okay? What's the nerve supply here? What the nerve supply above the dentate line? Huh?
It will be the autonomic nervous system.
Autonomic nervous system. This is pain sensitive or pain insensitive?
Not pain sensitive.
Not pain sensitive. This is why the internal, usually the internal hemorrhoid above the dentate line or below the dentate line.
Above the dentate line.
Okay, how the internal hemorrhoid is presenting? Painless.
Painless.
Okay. What the nerve supply here?
Systematic nerve.
What the name of the nerve?
Supradendal nerve.
Pudendal nerve. Very good. Somatic nerve. Meaning this is pain sensitive or pain insensitive?
Pain sensitive.
Okay. Where is the fissure happening? Here above the dentate line or below the dentate line?
Below the dentate line.
Below.
How the fissure presenting?
Painful.
Painful. This is the sensitive area. Clear until now?
Yes.
Okay, sure. Okay. What the blood supply here?
There will be
What the blood
superior,
supply here?
will be superior and middle rectal artery.
Here the superior rectal artery.
Yes.
Okay. What about here?
Will be inferior rectal artery.
Inferior rectal arteries. Okay. What the lymph drain here?
Be the supermesenteric nodes.
Same like rectum.
Yeah.
Same like rectum.
Inferior mesenteric nodes.
Yes, inferior mesenteric node, internal iliac nodes here. If that you have cancer here, which lymph node is the larger? Below the dentate line.
Between the internal iliac nodes.
Here, below the dentate line, where is the lymph drain? If I have friction or I have cancer here, where the which lymph node is the larger? Below the dentate line here. Did you see my mouse? Where? Anybody?
Inguinal.
Inguinal, bilateral inguinal. This is why, you know, when patient having anal cancer, one of our important examination, we need to examine the inguinal lymph nodes. Okay. Also, when we're staging them, we need to look for inguinal lymph nodes. Part of the treatment of anal cancer, we need to do lymphadenectomy for inguinal lymph node if it is involved. Because in this area, you know, draining to bilateral inguinal lymph node. Clear?
Yes.
Okay, sure. Okay, what's the relation? Okay, the relation, same, male and female. You know, both of them, they have perineal body in front to the inner canal. Male, they have membranous urethra with bulb of the penis. Female, they have lower end of the vagina. Posterior to the anal canal, coccygeal ligament, tip of coccyx. Laterally, rectal fossa. Around here, if I go back, you see it, and around it is the sphincters. Clear?
Yes.
Okay, you see this is the blood supply of the anal canal. You see this is internal pudendal artery, anterior rectal artery. This is supply the area below. You see the bacterial line here, below the bacterial line. You see branch of superior rectal artery supply the area above the dentate line. Clear? This picture. Confirm what we discussed earlier. Clear?
Yes.
This is the venous drain. You see it? Below the dentate line, above the dentate line. Same. The veins follow the artery by same name, corresponding. Clear?
Yes, Mr. Madam.
This is the lymph node. You see? Pararectal lymph node. After that, going to the internal iliac lymph node, going to the severomesenteric lymph node. This is above the dentate line. Below the dentate line, superficial inguinal lymph node bilaterally. Clear?
Yes.
Okay, this is the nerve supply. Above the dentate line, autonomic nervous system. Below the dentate line, somatic nerve, as we discussed. Okay, inferior recta coming from the pudendal. You see, below the dentate line, pain sensitive zone. Above the dentate line, pain and sensitive zone. Clear? This is the, and we discuss what lesion can be happening. Okay, this is, you know, this is the last part from my slides. This is, you know, the sphincter around the inner canal. Internal sphincter coming from the smooth muscle. Continuation from the muscle from the rectum, usually surrounding the upper 2/3 of the anal canal. The nerve supply for the internal sphincter is from where? I said smooth muscle, continuation from the muscle from the rectum, the internal sphincter. Nerve supply from? Autonomic.
Okay. Oh, internal, yes.
Yes, internal is autonomic, okay? For external, you see there is 3 parts of external. Subcutaneously, superficial, deep. Which muscle this one?
From levator ani.
Elevator. You see the elevator, you know, can be contributed part of the deep external sphincter. This is what type of muscle is external sphincter? What type of muscle?
Tricep muscle.
Skeletal.
Yes, skeleton. There's voluntary or involuntary.
Voluntary.
Voluntary.
Voluntary. For the internal sphincter, voluntary or involuntary?
Voluntary.
Involuntary, smooth muscle. This is skeletal muscles. Okay, what's the nerve supply here? External sphincter. Within the nerve, somatic. Within the nerve, somatic. This is autonomics. Okay? Clear?
Yeah.
Clear.
I'm done, guys. I passed the time or I'm okay?
What's the time are you, Mr. Mehta?
I'm so sorry for that. Okay? Okay. Any questions?